Welcome lecture on mood disorders for clinical psychopathology. Before we start talking about the disorders, let's just clarify some terms that will be used frequently when talking about the disorders. Emotion, affect, and mood. Right. So when we're talking about emotion, we're talking about a state of arousal defined by subjective states of feeling, which means I feel happy, I feel sad, right? Which only you know how you feel. That's why it's a subjective state of feeling, and it's associated with some level of arousal or some change in physiological functioning from kind of the status quo. When you experience emotion, your body's doing something different than typical, than kind of baseline, and you feel subjectively different. Right? Affect, then, is a pattern of observable behaviors, like facial expressions, that are associated with the subjective feelings. So affect is the outward display of emotion. So if we talk about people having blunted affect, they're not showing a lot of emotion. We often assume that means they're not feeling emotion, but we can't measure what the subjective state, but we can measure affect. And so that's one reason so often we'll talk about affect instead of emotion, because it's something observable. So kind of the observable indicators of someone experiencing emotion. And then mood is just emotion stretched out, right? It's a pervasive and sustained emotional response that might affect a person's perceptions, right? So if we think about, we've talked about before, anxiety and fear. Fear is to anxiety as emotion is to mood, right? So mood is how that subjective state of feeling and your level of arousal over some long period of time. So you might, something happens, you feel really happy, and then you come back to baseline. But if you stay in kind of this happy place over a period of time, then we start saying, okay, you didn't experience emotion, now you're in this mood state, you have a happy mood. So it's all about time. When we talk about mood, we use a couple of different terms. Some you're familiar with, some you may be less familiar with. We talk about a depressed mood, and that can be used interchangeably with dysthymic mood. A dysthymic mood means depressed mood, so feeling low, right? Feeling sad, kind of a low energy, even more so than sadness. And then an elated mood, or a manic mood, or a euphoric mood, and this is all kind of high energy, so feeling very positive, and feeling very good about everything and yourself. And again, the difference between a dysthymic mood and a euphoric mood, it's the essential element seems to be energy, more so than this kind of subjective feeling state of happy, sad. Depression is really about lack of energy, and euphoria is about having lots and lots of energy at a psychological level. Then we also talk about a dysphoric mood, which is just a general term, often similar to depressed, dysthymic, but dysphoric mood just means unpleasant mood. So it encapsulates, encompasses depressed and dysthymic mood, but it also would, somebody experiencing a dysphoric mood also might have some experiences of anxiety. Right, so dysphoria is just kind of bad mood, not pleasant. Okay, and then euthymic, that's when we talk about normal mood. So, and it's usually, when we say normal, slightly positive, but not euphoric. So between euphoric and dysthymic, but slightly above the, if we imagine this kind of imaginary zero mood line, slightly above zero. So a little bit positive, but generally if you're going through your day and you're not experiencing a mood disorder, you're probably experiencing a euthymic mood. Okay, on to the disorders. So, a big overview here. The disorders we'll talk about include major depressive disorder, bipolar 1, bipolar 2, and then cyclothymic and dysthymic disorder. Now, primarily, the mood disorders are defined by the presence or absence of particular mood episodes, either currently or in the person's past. So we'll come back to these disorders after we've talked about criteria for mood episodes, but just kind of highlight that a major depressive disorder is when you've had, have now, or have a history of one or more major depressive episodes, and you've never had these other mood episodes, so just depression. And often that's referred to as unipolar depression. Although conceptualizing it as a polarity, probably not the best idea, but the name stuck. So bipolar, when you go from one pole to the other, which again, not really, is when you have one or more manic episodes or mixed episodes. We'll talk about what those are. And then you might have had or currently have a depressive episode too. So some depression, but definitely some experience of manic symptoms. And then bipolar 2, you have to have at least some hypomanic symptoms. And then you must have depression, but then you can't have ever had full manic symptoms, which lead to a manic episode or mixed episode. And then cyclothymic and dysthymic disorder are kind of like chronic depression and chronic bipolar disorder, where you don't have any mood episodes except for if you have cyclothymic disorder, you might have hypomanic episodes. But basically, cyclothymic disorder is when you're kind of going up and down. So some kind of hypomanic symptoms, maybe even hypomanic episode, and then some depressive symptoms. But you never get so depressed that you have a major depressive episode, and you never get so manic that you get a manic episode. So kind of up and down, which is kind of like a chronic bipolar. It's over a long period of time. And dysthymic disorder is the same thing for depression, where you have a lot of depressive symptoms, but never to the severity. Well, at least never to the severity that you meet full criteria for a major depressive episode. But you have it for a long time. And we'll come back to each of these disorders. I just kind of want to let you know where we're going. So before we can talk about the disorders, though, we have to talk about the mood episodes. So, major depressive episode. And there's DSM criteria for the episode, and just like with a panic attack, you cannot diagnose someone with an episode, but they're criteria because the disorders are based on the presence or absence of these mood episodes. So we have to define them in the DSM. So it's analogous to a panic attack in panic disorder. You can't be diagnosed with a panic attack, but you can be diagnosed with panic disorder. And you can also be diagnosed with specific phobia that features panic attacks. Same thing here with a major depressive episode. It can occur in major depressive disorder. It can also occur in bipolar 1 and bipolar 2, okay, depending on what the other mood episodes that are present or have been present. So what is a major depressive episode? This is what we talk about when we talk about being depressed, right? So 5 or more of the following symptoms present during the same 2-week period. Right, so the mood episode has to be at least 2 weeks long and represents a change from previous functioning. At least one symptom is depressed mood or loss of interest or pleasure. When we talk about loss of interest or pleasure, another term you may hear is anhedonia, and that's what it's referring to. When things that used to do them and they were fun, now they're not fun, or you're not interested in doing those fun things. Okay, a couple of things. So 2-week period. Which can be longer. I think the average length of a major depressive episode is about 4 months, but it can be as long as 2 years, which we'll see in a minute. It represents a change from previous functioning. So again, remember I kind of said before about there's this kind of dysthymia where you're always depressed. There's got to, even if you're fairly depressed, this has to be going down further, or if you're at a normal mood or a manic mood, really dropping down. So you're somewhere, usually euthymic, and then there's a difference. Okay? And with a major depressive episode, in major depressive disorder, it can be kind of a gradual, where things, you experience some dysphoria, anxiety, and then it drops down. It's not necessarily a rapid shift, but it is a shift that is noticeable to the person and probably to those around that person. Okay, but the symptoms, so 1 and 2 are the mood symptoms. 1, depressed mood almost all the time, more days than not. Although in youth, it can be irritable mood instead of depressed mood, which is a bit problematic diagnostically, or diminished interest or pleasure in most activities, almost all the time, which is your anhedonia. Okay, so you have to have at least one of those two. You could have both, right? But you have to have at least one of those two. And note here that to be diagnosed with a major depressive episode, which is key to major depressive disorder, you don't have to have depressed mood. If you have loss of interest or pleasure, then that's good enough. And sometimes, just kind of clinically speaking, you'll see that people that have been depressed a long time, they've been depressed so long that they're not sad anymore. Their mood is not depressed in the way we think of sadness and crying, and they're more just kind of numb, and they have no energy to do anything and not interested in doing anything fun. There's no joy in life, but they've gotten to the point where they've worn out the sadness. I think that's one reason why you have you don't have to have depressed mood to be diagnosed with depression. You might have a significant change in weight or appetite, so weight gain or weight loss, increase in appetite or decrease in appetite, change in sleep, either insomnia or hypersomnia. And then in terms of your psychomotor functioning, you can have, again, it's weird how things can go one way or the other, but basically things getting off kilter. So psychomotor agitation, so being kind of jittery, or psychomotor retardation, where you're moving much more slowly than normal, which would be more common. And then fatigue or loss of energy, and this is one that's not, so far we've had things going both ways. More appetite, less appetite, more sleep, less sleep. Fatigue and loss of energy, that's one way for depression. If you have more energy, that's not depression, right? Because one of the essential features of depression is this kind of loss of energy, low energy. So fatigue, loss of energy, and then similarly here we get into things that are more clearly depressive, and it's kind of one way. Feelings of worthlessness or excessive inappropriate guilt. People that feel really good about themselves, probably not experiencing a major depressive episode. Diminished ability to think or concentrate, or indecisiveness, so we have some cognitive symptoms, and recurrent thoughts of death, recurrent suicidal ideation, suicidal attempt, or a specific plan for suicide. Okay. So notice in here we have this kind of mixture of symptoms, this interesting constellation. There's some cognitive stuff in terms of the worthlessness and the guilt and the concentration, the thoughts of death, some behavioral stuff in terms of suicidal attempts, some emotional stuff with the depressed mood, and then some very kind of physical, biological stuff with the change in the weight or appetite, and the sleep disturbance and psychomotor changes. So there's all these different clusters of basically emotional, cognitive, and somatic symptoms. Somatic being the body stuff, right? And those three clusters of symptoms are maybe present to a greater or lesser degree in different individuals when experiencing a major depressive episode. And some research, kind of getting ahead here, some research suggesting that there may be ethnic differences in terms of what types of symptoms are more prominent in their expression, because people are kind of taught by their culture, when ethnicity is correlated with culture, how to express their sadness and how not to, what things to not do or not display. Okay, so you have a lot of symptoms, 5 symptoms during the same 2-week period. So it's not like couldn't sleep one night and then a few days later didn't feel hungry. It's more chronic than that. So over this period, these symptoms are prominent. And then we have a kind of rule out here. It's not a mixed episode, which that'll make more sense when we talk about what a mixed episode is. But basically, a mixed episode is when you have depressive symptoms and manic symptoms at the same time, in the same time period. Okay, so it's not that. So we have our rule out stuff. It does cause clinically significant distress or impairment to meet criteria for a mood episode. It's not due to a substance or general medical condition. And there are some medical conditions that do seem to play a strong role in the etiology of depression that can actually cause depression in terms of Cushing's disease and sometimes late-stage HIV can be associated with depression because there's this kind of pathophysiological connection between the disease and the experience of depression. So not that. If that's the case, it's a different diagnosis. It's mood disorder due to a general medical condition. But for a mood episode, it's not caused by substance, not caused clearly by general medical condition. You might be upset about being diagnosed with something, but the disease itself isn't causing the depressive symptoms. And then it's also not bereavement, which is interesting here. With this said, if you've lost a loved one, then it's okay to have all these symptoms. But it's only okay for about 2 months. And they got in a room and raised their hand to decide how long you could be sad about someone dying, and they thought 2 months was enough to have this amount of impact of the loss. For 2 months, you can have all the symptoms and not have a mental disorder, but if you still have symptoms 2 months and 1 day, it's a mental disorder. Or if your symptoms are severe, so if you are really upset about losing someone you love, and you can't eat and you can't sleep, and you feel guilty about not spending time with them, all these things, and you're sad every day for 2 weeks straight. If it causes impairment where you can't go to work because you're so upset, you would meet criteria for a major depressive episode. Okay. Which is tricky, and that kind of not bereavement rule out is just for kind of clearly bereavement loss related to death. So if you have a loss not related to death, divorce, loss of custody of your children, even though that can look very much like other bereavement, technically wouldn't count. Although practically, if you're when you're practicing, if somebody has all these symptoms and they just experienced a significant loss, you would probably treat it more like bereavement than a major depressive episode. Although, depending on your theoretical stance, what you do with the person may or may not be that different if you conceptualize it as kind of a bereavement or even complicated bereavement versus depression. Okay, so that's a major depressive episode, which can occur, again, in depression. Unipolar depression can also occur in the course of bipolar depression. Very different from a manic episode, right, which manic episodes occur only in bipolar 1. Not major depressive disorder, and not bipolar 2. If you have now or have ever had a full manic episode, the only mood disorder of those three, the only mood disorder you can be diagnosed with is bipolar 1, not bipolar 2, and not major depressive disorder. Well, not dysthymia. As we'll see later, you might meet criteria for cyclothymia, but the others, it's just bipolar 1. Okay, so a manic episode. A distinct period of abnormally or persistently elevated expansive or irritable mood, lasting at least 1 week or shorter if hospitalized. Okay, so generally we think about it being elevated expansive mood, but it can be irritable mood, where you're just kind of really pissed off and maybe angry. And this is where it gets a little tricky if you work with kids and adolescents, because you remember, if we think back to depressive episode, right, primarily depressed mood, but maybe irritability in kids. So the irritable mood can be manic or can be depressed, which is seems wrong. But generally, it's the presence of these other symptoms that will tell you if that's a depressive episode or a manic episode. So it's a bit problematic to have irritability be the primary thing for a major depressive episode. It seems to be more consistent with mania. At least a week. And if short of hospitalized, that's because if you are exhibiting all the symptoms of mania, which one of the criteria we'll see in a minute is it causes impairment. If you're impaired and you're manic, they're going to stop you being manic when you go to the hospital. So if you've been manic for 2 days, you go to the hospital, they're going to shoot you full of drugs to bring you down, and you're no longer going to be showing the symptoms. But we still think, the thing is, we assume if they hadn't shot you full of drugs, you would have continued to show the symptoms. And that's why the duration is shorter if hospitalized, because there's the assumption that it would have continued if left untreated. Okay. So, again, it's a different, it's not just feeling, I feel really good today. It's a distinct, subjectively different experience of feeling really, really good, or really, really irritable. And then you have 3 symptoms, 5 for depression, 3 for mania, 3 symptoms present. Although you have to have 4 if it's irritable mood, because again, mania seems to be primarily about feeling really good. So since irritability is kind of like, oh, that's a little off and it overlaps with depression, we're going to make you have 1 more symptom to make sure that it's mania and not a depressive episode or possibly a mixed episode. Kind of be more clear. Okay, so inflated self-esteem or grandiosity, so you think you're great, and you might even think you have godlike powers or that you are God. Right? It can get to that level where it seems almost delusional. It can look a little bit like a psychotic disorder, almost like schizophrenia for some individuals. Decreased need for sleep, and this isn't just insomnia where you can't sleep. You don't need to sleep. You can stay up for 36 hours and not be tired. Sleeping for 4 hours a night and not be tired. Which, if you had an infant at home, that would probably be really helpful to have that little piece of mania. extra talkative or pressured speech. So more talkative than usual. Pressured speech is what happens sometimes when I'm lecturing. Like if I said, "Oh, it's a really distinct period of normally persistently elevated expansive mood," and mood and lasting, trying to get out, talking so quickly and pushing the words out, right? As if they have so much to say and no time to say it, and their brain seems to be going so fast. That's what pressured speech is like. There's pressure behind the words, pushing them out. Okay. So extra talkative, pressured speech, flight of ideas or racing thoughts, which again, you can't see their ideas, so this is usually based on their speech patterns. So jumping from one topic to the next. So, oh yeah, I didn't tell you the day I went and I got my dogs, took my dogs to the groomer. And speaking of the groomer, I saw this groom at this wedding, and there was such a nice wedding, and they had great flowers. And I love flowers. And flower power was a cool thing in the 60s. And so just kind of going from one thing to the other, just barely catching one tangent to the next. And sometimes it may not even be apparent what the relation is from one idea to the next. Although it's, let's say it's different than psychotic thinking. We'll get to talk about schizophrenia later. We'll talk about disorganized thinking and schizophrenia. That's really hard to follow and really hard to kind of follow when going from one subject to the next. With flight of ideas and racing thoughts, with mania, often you can kind of discern, okay, I can see where you went from here to here, but they're going at a faster rate than most people do and covering more subjects than most people would. Distractibility, pretty straightforward, kind of looking a little ADHD-ish here. And then, if you're lucky, you get the increase in goal-directed activity. This is whenever you get a lot of stuff done. So you paint the house, mop the floors, build a statue out of Play-Doh, do all your homework for the year, all of that in one night. So it's not just aimlessly bouncing around. It's getting a lot of stuff done, accomplishing goals. So goal-directed activity, working toward getting things done. On the downside, potentially, there's could be excessive involvement in pleasurable activities, which is usually good, but pleasurable activities that are dangerous. You have negative consequences. Going on having non-exclusive kind of random indiscriminate sex, shopping sprees beyond what can be sustained by your bank account, things that can eventually cause you harm. But it's kind of going out to do stuff that feels good, even though it's dangerous. Regardless of the danger, focus on seeking pleasure. Right? And then we have our rule out stuff, right? It's not a mixed episode. The symptoms cause impairment, require hospitalization, or include psychotic features, but the symptoms are not due to a general medical condition or a substance, so you're not just high. Okay, so we've got a good idea of what a major depressive episode is and what a manic episode is. So then a mixed episode is pretty straightforward. It's a combination, right? So where criteria have been met for both a manic episode and a major depressive episode for 1 week. With the one little exception being for a major depressive episode, typically you need 2 weeks of symptoms, right? But for a mixed, all you need is the 1 week, because the manic part usually doesn't last, or not usually, but it doesn't have to last for more than a week. Okay. Then still you have to have symptoms cause distress or impairment, and they're not due to a general medical condition or substance. Okay. So again, you've got during this 1 week period a lot of depressive episodes, so you may have really depressed mood for a day, and then you may be really grandiose the next, or it might be on some days you might have symptoms from both. It can be truly mixed. So you have a major depressive episode, a manic episode, then a mixed, which is just a combination of two, and then you have a hypomanic episode, which is hypo less than, right? So it's less than manic, right? So still it's a distinct period of persistently elevated expansive or irritable mood, right? Which is verbatim same thing as manic, except for it's 4 days instead of a week, and it's still different from typical non-depressed moods. So it's not just I feel pretty good. It's still more than just feeling pretty good, but it's a lot like feeling pretty good. And then you have to have at least 3 symptoms from criterion B of manic episode, which that criterion B is that inflated self-esteem and grandiosity, decreased need for sleep, extra talkative, pressured speech, flight of ideas, distractibility, goal-directed activity, excessive involvement in pleasurable activities that are dangerous, yada yada, all this stuff. So all the stuff that is mania. If you have 3 of those symptoms with this 4-day period, And the episode is uncharacteristic and an unequivocal change in functioning. So again, not just I'm feeling a little better, things are going well, I got a raise, oh, and then I got a new car, I'm feeling pretty good. It's really something different than your regular mood, right? And not that you're always kind of this cheery, happy person, which some people are like that. God bless them. But happier than you characteristically normally are. Right? And the change in mood and functioning must be observable. So we've got a couple more criterion here from the other episodes to make sure that it's a mood episode, because this is closer to normal mood, right? We have kind of normal euthymia, and then depression and mania fairly far away. But hypomania is closer. It's kind of halfway between euthymic mood and manic mood. So we have these other criteria saying we really got to be sure this is something different and not just being happy. Notably, symptoms must not be severe enough to cause impairment or hospitalization, which is interesting. And again, one reason why you would never diagnose somebody with a hypomanic episode, it's not pathological in and of itself. So if all you have are hypomanic episodes, there's no disorder with that. You know, if you have euthymic mood and hypomanic mood, but you never really experienced depressive mood episodes or a lot of depressive symptoms, you're just a fortunately happy person. Good for you. Because again, this mood episode doesn't cause impairment. And the symptoms are obviously still not due to a general condition or use of a substance. And so you're wondering, well, if it doesn't cause impairment, why are we even talking about it? Well, because if it occurs with depression, then that's one form of bipolar disorder, bipolar 2, which we'll talk about down the road. And if it occurs with depression, the depression must cause impairment, right? Clinically significant impairment, and then it becomes a disorder. And we describe hypomania to distinguish people who have just plain old regular old unipolar depression and those that have depression, and then they have these episodes of hypomania, with the idea being that, well, they probably respond to treatment differently. Okay. So now we get to the disorders. So major depressive disorder, one or more major depressive episodes, and the diagnostic code, the number used, depends on if it's one episode, if you're currently in one or have only had one, or if you've had more than one. If it's one, then it's major depressive disorder single episode. If it's more than one, major depressive disorder recurrent, right? And they're different numbers. Because again, it's thought that they might be different. Although once you have a major depressive episode, you're more likely than the general population to have another one. And once you have two, you're more likely to have another one than somebody who just had one. And once you have three, you're more likely than somebody that's had two. So the more you have, the more likely it is you will have more. So there is something to this kind of recurrent theme. So the major depressive episodes, so all those symptoms we talked about before, in terms of depressed mood or anhedonia, impaired concentration, messed up sleep and appetite, all those symptoms are not better accounted for by schizoaffective disorder, and they're not superimposed on a psychotic disorder. So schizoaffective disorder is where you have prominent mood symptoms, so probably a lot of depressive symptoms, and prominent symptoms of psychosis. But with schizoaffective disorder, you have psychotic symptoms in the absence of mood symptoms. So when you're not depressed or not manic, you still have your hallucinations and delusions. And that's what kind of separates schizoaffective from a mood disorder. Because mood disorders, you can have psychotic features, which we'll get to, but you only have them during a mood episode. If it really is a mood disorder, you don't have the hallucinations and delusions when you're not depressed or manic. Okay. But if you have them outside of that, then it's probably schizoaffective disorder, or it might just be some other psychotic disorder, schizophrenia, delusion disorder, that is influencing some mood symptoms. And kind of feeling depressed because you think the CIA or the aliens have taken your brain. We wouldn't diagnose you with major depressive disorder on top of that if it's really better explained by the psychotic disorder. Okay. Has to be no history of a manic, mixed, or hypomanic episode. So that means that if the first mood episode you ever have is a major depressive episode, and you get diagnosed with a major depressive disorder, if you ever have a manic episode, a mixed, or a hypomanic episode, your diagnosis changes. You no longer have major depressive disorder. Now you have either bipolar 1 or bipolar 2. Okay? But if all you ever have is a depressive episode or multiple depressive episodes, then it's major depressive disorder, pure depression, unipolar depression. And then for the most recent mood episode, which for major depressive disorder must be a major depressive episode, you can tack on a specifier to kind of clarify some more information, with the idea being that these specifiers, the more we describe it, it might be indicating different types, kind of subtypes of depression. Oh, you have this type or this type, and based on the specifier, based on the subtype, we might expect different things about the course of your disorder, and also about how you might respond to treatment. And the evidence, a mixed bag of evidence, how much these specifiers tell us. Severity is fairly important. It ranges from mild to moderate to severe, and then severe, it can be severe with psychotic features or severe without psychotic features. As I said before, you can have psychotic features with a major depressive disorder. So when people are really depressed, they can hallucinate. They can have delusions. So if they're really depressed and they're having hallucinations that their dead child is talking to them, they're not necessarily psychotic in terms of they don't necessarily have a psychotic disorder like schizophrenia. As long as those hallucinations, delusions only occur when they're really depressed. If when they're not experiencing a major depressive episode, so if they're back to a euthymic, a normal mood, or a slightly depressed mood, and they're still having hallucinations, delusions, then yeah, it may be something else. But it can occur during severe major depressive episodes. You can have psychotic features. You can also add the specifier to denote chronicity, and really it's just chronic or not. And a chronic episode, and chronic again applies to the episode, not to the disorder per se. So it's a chronic episode if it's lasted for 2 years or more. Which, think about that for a second. 2 years of more days than not feeling depressed and not being able to sleep and being tired all the time and feeling excessively guilty and thinking about suicide. That's heavy, right? And that's you're probably going to have severe depression if it is that chronic. Okay, and like I said before, I think major depressive episodes typically last, on average, 4 months. But again, they can be as short as 2 weeks. Then you can also specify other features, and there's a variety of features you can see with catatonic features, which is can also be applied to manic episodes, but not, and mixed, but not hypomanic. This is whenever you have motoric immobility, as evidenced by catalepsy or stupor, so where you can't move, or you don't move, or the opposite, excessive motor activity that is apparently purposeless, so kind of hands and legs moving back and forth and not doing anything. They're not waving at you, but it looks like they are. Extreme negativism, which means they aren't doing it. You tell them, hey, come here, and they don't move. They can't seem to motivate themselves to get up and do things, even if it might be good for them to do it. Not talking, mutism, stereotype movements, grimacing, echolalia or echopraxia, repeating what people have said or movements people have made. And typically, major depressive disorder with catatonic features is typically with a more severe episode. You might also have melancholic features. You're thinking about the history of talking about depression. It used to be called melancholia, so we still have the melancholic specifier, which applies to what a lot of the early writers were writing about when they were writing about depression, which melancholic features only apply to depressive episodes. And this is when you have a loss of pleasure or lack of reactivity to pleasurable stimuli. So it really has that anhedonia part there. And then you might have depressed mood, but you also might have things that are kind of a little different. Depression being worse in the morning, psychomotor symptoms, the retardation or agitation, loss of appetite or weight loss, and excessive guilt. And then you might also have atypical features. So this is, as the name implies, not usual. So knowing what the atypical features are gives you an idea of what the typical ones are. Atypical features involve mood reactivity. So that means in Experience Made First episode, but watching Talladega Nights with Ricky Bobby and laughing. So if you laugh at stuff while depressed, that's atypical. Most people experiencing major depressive episode, even if something that they would typically find funny, not able to find it funny, not able to laugh. Their mood doesn't react to stimuli. But the atypical depressive episode may happen. And then weight gain, so again, weight loss is more common. Increase in appetite, so typically people have a decrease in appetite and lose weight. Although you may hear people talking about weight gain, struggling with depression, that's usually because of the medications, which again kind of makes sense. Well, okay, if the disorder is associated with weight loss, then medication that fights the depression might be associated with the opposite reaction. Side effect of a lot of medications is weight gain. But again, atypical depression is associated with weight gain or increased appetite. Hypersomnia, so sleeping a lot. Typically, you don't sleep much. Leaden paralysis, which isn't that all that untypical. And then a couple other things which aren't that atypical. And then the last kind of feature thing you can specify is with postpartum onset, which applies to a major depressive episode or any other mood episode for that matter, other than hypomanic episodes. And this is it if the onset of symptoms is within 4 weeks of having a baby, which DSM-5, just kind of a side note here, is looking at extending that 4 weeks to, I think, 6 months, because the researchers suggested that postpartum depression can occur and start longer than a month after having the baby. And then if they don't currently meet full criteria for a mood episode, so they did a week ago or 2 weeks ago or a year ago, and now they're coming in and being diagnosed, you can specify in there in terms of where they're at in their remission, and it's remission of symptoms of a mood episode, not of depression itself. Not the whole disorder, just the mood episode. And it's either full remission or partial remission. Right? So partial remission, obviously, you don't meet full criteria, but you meet most of them. For full remission, where you don't, that's when you don't meet any criteria. No, I'm sorry, you don't meet enough criteria, but it's the amount of time. Full remission requires 2 months. So until it's 2 months, if you don't quite meet criteria, you're short 1, you're short 2, whatever. But it's only been a month, partial remission. After it's been 2 months, that's full remission. And then related to that might be some of the course specifiers. If you have more than one mood episode, you can say if it's with inter-episode recovery or without inter-episode recovery. So again, this depends on if you achieved full remission or not. So if you had full remission between mood episodes, you have with inter-episode recovery, and if not, without. With the idea being that people who don't have inter-episode recovery, so they get really depressed and then they get slightly less depressed, but all their symptoms don't fully go away, or they don't go away they only go away for a month. That's thought to be associated with a poor outcome, poor prognosis, and people who are able to experience inter-episode recovery. And then last is the with seasonal pattern. This is if the onset of the mood episodes are related to the time of year, seasons, and not just because of life events correlate with time of year, like, oh, I always get sad in the winter, but it's because Dad died at Christmas. That wouldn't be with seasonal patterns. It's if it's clearly related to the season and not life events related to that, with the idea being it has something to do with circadian rhythms and the amount of sunlight, yada yada. And this is when people talk about seasonal affective disorder. You won't find seasonal affective disorder elsewhere in the DSM. This is it. It's a mood disorder, either major depressive disorder or bipolar disorder. Seasonal pattern. That's what seasonal affective disorder is in the current DSM. Okay. So that's major depressive disorder, often referred to as depression, although the word depression has been used so much that can be misleading, so I encourage you to use the full name when talking about the disorder, major depressive disorder. Bipolar 1 disorder, a current or previous manic or mixed episode. And remember, the key here is, a mixed episode requires meeting all criteria for a manic episode, but you just also happen to have symptoms of depression too during that period of time. So the key for bipolar 1 is at some point in time meeting all the criteria for a manic episode. Whether or not you also have some depressive symptoms there too, doesn't matter. All that matters for bipolar 1 is mania. Okay. So currently, most recently, sometime in the past, experienced all the symptoms needed for a manic episode. You may have a current major depressive episode when you come in and get diagnosed, or a history, or hypomanic episodes. Not necessarily. And people often think, oh, bipolar disorder, that's when you have mania and depression. Typically, yes, that's what you see. Not required for diagnosis. If somebody experiences a manic episode and that's it, and they've never had a major depressive episode, never had a hypomanic episode, it's still bipolar 1. Bipolar 1 is all about mania. But that being said, usually it's associated with depression, and usually close in hand where depression follows the mania. So coming down from the high, and instead of coming back to a euthymic mood, quickly progressing to a depressive mood. And you can experience hypomania as well, but not required for diagnosis. And still, we have the mood episodes are not better accounted for by schizoaffective disorder, not superimposed on psychotic disorder. So same thing I said before about depression, major depressive disorder applies here for bipolar disorder. And psychotic features not at all uncommon during mania either, especially delusions of grandeur. Somebody believing that they are talking to God, or that they are the son of God or daughter of God, or whatever. It seems to be related to that. So the delusions seem to be related to the mania, feeling really good about themselves and oneself being special. Okay. The mood episode specifiers, same things here, right? So in terms of severity, chronicity. The features, you can have catatonic and postpartum onset, but not melancholic or atypical to describe a manic episode. But if you have bipolar 1 and your most recent episode was a depressive episode, then you still tack on that, because that's again about the most recent episode. And then for the and remission, same thing. For the course specifiers, if there's recurrent mood episodes, some of the same stuff in terms of with or without inter-episode recovery, and there can be seasonal pattern. But that, interestingly, only applies if your bipolar 1 features depressive episodes. There doesn't seem to be a seasonal pattern related to mania. At least not that anybody's noticed or documented. That kind of depression that gets worse in the winter, usually. It seems to be the effect of the seasons, or the correlation with the seasons, however you want to look at it, is restricted to depression. But you could have that specifier if your most recent episode was a major depressive episode in your bipolar 1 disorder. And then the specifier that's different for bipolar disorder from depression is this idea of rapid cycling, which can be diagnosed in bipolar 1 or bipolar 2. They also made rapid cycling, so lots of mood episodes. So you're really happy, and then a few minutes later you're really sad. Not typically. Like rapid for rapid cycling is 4 mood episodes in 12 months. Right? Not 12 days, not 12 hours, 12 months. Over the course of a year, having 4 distinct mood episodes. Because remember, these mood episodes are typically not, a day long. They're typically, but by definition, a manic has to be a week. Depressive has to be 2 weeks. A mixed has to be a week. So it'd be hard to cram a lot of them into a short period of time. Most people don't go from really happy to really sad, really happy to really sad. If we see that kind of pattern, we start looking, okay, is this really their mood changing and seemingly without any clear cues in the environment, or do they have pronounced mood reactivity to where somebody says they can't go out with them, and they get really depressed, and then somebody else calls and says, hey, do you want to go out? And they get really happy. And so if they have these huge mood shifts or mood swings in reaction to environmental stimuli, that's not what we see so much with bipolar disorder. It's borderline personality disorder, which we'll talk about down the road. Pronounced mood reactivity, so reacting to environmental stimuli. These mood disorders, although they are associated with life events, there seems to be a stronger biological push in terms of when the moods change. And we'll talk in a minute. They are very much related to what happens to you, but it's not. The reaction isn't as swift as with personality disorder. Okay. But rapid cycling is if 4 episodes or more in 12 months. Okay. Bipolar 2, so a current or previous major depressive episode. So again, in bipolar 1, you don't have to have a depressive episode. Bipolar 2, you must. Because again, you can't have a manic episode and get bipolar 2. But you have to have a hypomanic episode. And you have to have the depressive episode, because if you just have hypomania, that's not pathological, right? Because again, hypomania involves no impairment. If it doesn't cause impairment, we're not going to call it a disorder. So bipolar 2 is if you have major depressive episode and at some point hypomania, either now or previously. But you've never had a manic episode or a mixed episode, because again, a mixed episode means that you met full criteria for a manic episode as well. And then the same type of thing we've seen before, the mood episode's not better accounted for by schizoaffective disorder, that's composed in psychotic disorder, right? So I'm getting kind of redundant here. The symptoms cause distress or impairment, and then the specifiers are the same as what we just talked about for bipolar 1. Okay. So again, bipolar 1, bipolar 2, it's mania or no mania. And if there's no mania, you have to have some depression, right? And if it's just depression, it's not bipolar disorder, it's major depressive disorder. So if it's going to be a bipolar disorder that has to have some depression, it must be something else there. That something else is hypomania. So depression and hypomania, bipolar 2. Mania with anything else, bipolar 1. Depression all by itself, major depressive disorder. Okay. And that's how you tell those apart. Now, for the more chronic stuff, we get to dysthymia and cyclothymic. So dysthymic disorder is kind of like a drawn-out depression, right? So it's chronically depressed mood for 2 years. So where somebody is depressed, has a depressed mood for most of the day, more days than not, as indicated by subjective accounts, so they tell you, or other people observe that they look depressed for 2 years. But in kids and adolescents, again, we have this. It can be irritability, and it can just be 1 year. So this is we'll talk about kind of the Eeyore in Winnie the Pooh. He seems a bit dysthymic, just always kind of down and nothing. He's not gonna. Eeyore's not gonna kill himself. He's not suicidal, but he's just always low. Right. So while the person is depressed during those 2 years, they have at least 2 symptoms, usually more, but for diagnosis 2 symptoms: poor appetite or overeating. So again, opposites of the spectrum here, but some disruption in appetite, some disruption in sleep, could be insomnia, could be hypersomnia. Again, low energy or fatigue, so not feeling really good, not lots of energy. This is like depression, so it's low energy, low self-esteem, not feeling really good about yourself, poor concentration, difficulty making decisions. So a lot of overlap here with criteria for a major depressive episode, right? And some things that are slightly different, feelings of hopelessness, which hopelessness often associated with a major depressive episode, but for some reason not part of the diagnostic criteria. Don't know why. And then here's the thing. During this 2-year period of mood disturbance, there was never a 2-month period where the symptoms were absent. So if you're like this for a year, and you're an adult, and then you have about 3 months, well, yeah, something happened, I feel pretty good, I shook it off, and then I went back to feeling that way. Not going to call that dysthymic disorder unless you can stay that way for 2 years, which seems a bit weird. But the real kicker is no major depressive episode during the first 2 years of the disturbance. Right? So if you're feeling really depressed for a year, but you don't meet full criteria for major depressive episode, so either you don't meet enough symptoms, or the impairment's not there, they're not severe enough. I feel a little bad myself, but not too bad. So you should really have 2 symptoms that meet criteria for an episode. So you maybe that's what it is. So you meet criteria for dysthymic disorder, but not a major depressive episode. But you're not dysthymic yet because it hasn't been 2 years. And then let's say something happens and it gets worse, and now you do meet full criteria for major depressive episode, and then eventually your mood recovers enough that you go back to being kind of slightly depressed. That would not be dysthymic disorder. That's major depressive disorder. And this thing with major depressive disorder, again, you might be kind of dysphoric and a little bit sad for a while before the full moon episode hits, but you only get dysthymic disorder if you can go a full 2 years before the major depressive episode. And that's the thinking is that this is kind of a characterological thing. Somebody who's been like this for a long time is probably always kind of like this, so it really fits more with personality disorder the way it is now. DSM-5 might change it if they change the name to chronic depressive disorder. But if you can go 2 years and then have a major depressive episode, then yeah, you still get your dysthymic disorder, but then you get major depressive disorder on top of it. And if you have both of those diagnoses, they call it double depression. Right. You also have no history of a manic, mixed, or hypomanic episode, and you don't meet criteria for cyclothymic disorder, which we'll talk about in a minute. So yeah, you wouldn't expect anybody with dysthymic disorder to ever have a manic episode or mixed episode. So if you have the diagnosis of dysthymic disorder and you have a manic episode, your diagnosis would probably change then to bipolar disorder, and you would no longer carry that label of dysthymic disorder. Again, not exclusive to a psychotic disorder, not due to a substance or general medical condition. The symptoms cause distress or impairment. Or some people can be just kind of sad and sullen, and it doesn't get in the way of their lives, and they wouldn't have the disorder. But if it causes impairment or it bothers you, it's a disorder. And then you have specifiers. The onset either early or late. Before 21 is thought to be early, and after 21 is late. So I guess 21 would be right on time. And then you can also add the specifier of with atypical features, which are the same things, atypical features for a major depressive episode. The same things apply to atypical features for dysthymic disorder. Okay. So kind of a chronic depression, but not bad enough to meet criteria for a full major depressive episode. Okay. So it's kind of like chronic depression. So cyclothymic disorder then is like a chronic bipolar disorder. This is where you have numerous periods, so a lot of points in time, a couple days, a couple weeks, whatever, with hypomanic symptoms and depressive symptoms. And the hypomanic symptoms, they can meet criteria for a hypomanic episode, and you could have a hypomanic episode and still meet criteria for a cyclothymic disorder. But if your depressive symptoms are severe enough to warrant a diagnosis of a major depressive episode, it's not cyclothymic disorder. So the depression isn't that bad. It's kind of I get happier than euthymic, and I get sadder than euthymic, but it doesn't go to the extremes. But I go back and forth over time, and you've done it for 2 years. And during the 2-year period, there was never a 2-month period where symptoms were absent. So never kind of fully recovered. It's kind of just how you are, or at least were, for these 2 years. And there was no mood episodes, so no manic, mixed, or major depressive episode, other than possibly, it's okay if there's a hypomanic, during the first 2 years. So if you have 2 years of this, and then are manic, you could have bipolar 1 and cyclothymic disorder. So like we have double depression, it'd be like double bipolar disorder, but nobody calls it that, so don't use that term. But the same idea applies that you can have dysthymic disorder and then depression, and you can have cyclothymic disorder and then bipolar disorder. Okay. And potentially you could have cyclothymic disorder and then major depressive disorder, so long as you never had a full hypomanic episode. But it'd be more likely that you would get a bipolar disorder, bipolar 1 or bipolar 2. Just because if the mood episode you have is manic, it's bipolar 1, and if the mood episode you had is depression, major depressive episode, if your hypomanic symptoms ever met criteria for hypomanic episode, well, now you have a history of hypomanic episode, a current major depressive episode, and that's what bipolar 2 is, right? And again, not exclusive to a psychotic disorder, not due to drugs or a medical condition, and the symptoms cause distress or impairment. Again, we all have ups and downs, but this is more up than usual, more down than usual, and this pattern of symptoms causes you problems or you don't like it. Okay, so we've talked about all the mood episodes. We've talked about the mood disorders, and there are others that we won't touch on that are just kind of mood disorder due to a substance-induced mood disorder due to a general medical condition. But these are the kind of the key mood disorders. We've touched on all those. But I think it's important to kind of go back now and think about, okay, well, when trying to decide if someone has a mood disorder and had a mood episode versus they were just feeling good because something good happened, or feeling bad because something bad happened. Because again, these mood episodes often are related to life events. So a major depressive episode doesn't usually come when things are going great for you. Usually it's after something bad has happened and you have a reason to be sad. Right? And even with mania, manic episodes often happen after something good happens to you, and you have a reason to feel good about yourself. So we have to be able to distinguish between normal mood variations and a clinical mood disturbance. Unfortunately, I'm just going to talk about this. So sadness or happiness without other symptoms is not clinical depression or mania. So if you're really, really sad, and it's deep, dark sadness, but it doesn't affect your sleep, doesn't affect your eat, you can concentrate when you need to, you don't feel excessively guilty, you don't have the other clusters of symptoms, you may be depressed, in terms of kind of colloquially we use that word to mean sad. Your mood is depressed, your mood is dysthymic, but you don't have the disorder, right? Same thing with mania. Somebody feels really good on this. They just got they just won a playoff series to go to the World Series, maybe. They may be, oh look, they're so manic. They're bouncing over the wall. They're so happy. They're talking a mile a minute. Yeah, kind of colloquially, they are manic. But unless they have the other symptoms, and unless it lasts for a week, it's not a mood episode. So we have to distinguish between using these terms colloquially in kind of everyday language and the mood episodes. So happiness, normal. Sadness, normal. And by normal, I mean it happens to everybody. And I want to be clear. I don't mean to imply that depressive episodes and manic episodes are abnormal, if you think of abnormal being wrong, but they are abnormal in terms of statistically they don't happen to most people. Okay, but again, abnormal being statistically rare is not bad, not necessarily pejorative. Okay, all right, so as I started to say earlier, really there's no clear line demarcating normal variation and mood disturbance. And we know if the symptoms are here, if they're not, but still those are fuzzy lines. Because even with the symptoms, it's like decreased appetite. Well, how much of a decrease in appetite is enough to call it a decreased appetite? I ate 4 chicken nuggets instead of 5. Is that a decreased appetite? Whereas if I ate no chicken nuggets, right? There's still some judgment calls in there. So there's not this clear line or any kind of diagnostic tests we can do to say, oh, this is feeling bad because something bad happened, and you're going to feel bad for a while, or this is a major depressive episode, and it's part of this disorder, which we can expect. If it's a disorder, we can expect certain things to happen because we've been studying people that have the disorder, so we know about the course of the disorder, and we know about the treatment of the disorder, that kind of stuff, right? Since there's not a clear line, we have to think about what might indicate the transition from one to the other. And often there is a transition. People who experience a major depressive episode, again, are non-clinically depressed before they're clinically depressed. They feel a little bad, and then it gets worse at some point and meets those criteria. So the transition, if the mood is pervasive across situations and over time, and obviously the time is built into the diagnostic criteria, and then across situations, it gets to that idea, with the exception of atypical depression, where you're depressed even if you leave one situation. So if you're at the hospital and a loved one is hurting and you're exhibiting all the symptoms of depression and you feel really bad, that might make a lot of sense. And they're in the hospital for a long time, so whenever you're there, you like that. But then if somebody comes to relieve you, you get some respite, and you are able to take a vacation to see some other family who are not sick somewhere else. If your mood then improves, okay, well then we think that was probably not a clinical mood disturbance. You were feeling normally sad, right? Appropriately sad. And again, fine line here. But if the situation changes and mood changes, then we think, okay, probably not mood disorder. The mood episodes can, if it is a true mood episode, the change in mood can come out of nowhere or be disproportionate to circumstances. And the coming out of nowhere is more often associated with mania than depression. People aren't usually surprised by depressive episodes, but they may be a bit surprised by manic episodes, and they may not be able to identify triggers for those as easily. And then, as I said already, the cognitive, somatic, and behavioral symptoms, which are built into the criteria, and then also the subjective experience of a different quality of the mood. So there's this kind of, I was kind of sad, but now, oh geez, this feels heavy and it feels different. I feel like I can't move, like I'm walking through mud, right? Or I feel like I'm top of the world and my mind's going a million miles a minute, and I'm not just happy. Wow, there's something different about it, and the person knows that it's different. And observers may or may not be able to pick up on that difference, but the person subjectively knows it's different. Okay, talk a little about the experience of mood disorders, the course and prevalence. So we're talking about onset for major depressive disorder and bipolar disorder. onset can be anywhere, but typically it's in the mid-20s. Like a lot of mental disorders, first diagnosed in the mid-20s when you become an adult, and more pressures on you in the world to fend for yourself. Job, school, kids, all that stuff. More likely to happen somewhere, on average, people in the 20s than when you're a teenager or later. For dysthymia and cyclothymia, it tends to be a bit earlier. Childhood or adolescence for dysthymia and cyclothymia, adolescence, early adulthood. So a bit earlier for those things. Again, they seem to be more characterological, so kind of how you are, your personality-wise, which should show up a bit earlier. In terms of prevalence, major depressive disorder will be the most common of the ones we've talked about, as high as 17% here in the States. And then dysthymic disorder will be behind that with 6%. And the next would be probably bipolar 1, somewhere around 1.6%. And it seems like, wow, bipolar disorder, it's everywhere, everybody has it. No, it's fairly rare, and rare relative to depression, relative to other diagnoses, not super rare. It's not like dissociative identity disorder. That is super rare. Bipolar disorder, common by that standard, but compared to depression or generalized anxiety disorder, bipolar disorder is still pretty rare. Bipolar 1 is 1.6%, bipolar 2 about 0.5%. So again, if most people that have those mood changes do have full-blown mania, and a lot of people that are initially diagnosed with bipolar 2 go on to have a full manic episode, and their diagnosis changes to bipolar 1. So if we add those two together, then we're up at about 2% of the population experiencing a bipolar disorder, and about half that, about 1%, experiencing cyclothymia. Looking at the gender ratios, and we often see these big differences between men and women, and we do see that in depression, at least in adults, in adolescents, twice as common in females than males. But if we look at major depressive disorder in children, about the same. So again, you have to wonder why does it change in adolescence and adulthood? And a lot of theories could be due to or associated with hormonal changes that happen in puberty, but also strong probability that a lot of it is related to our cultural sex roles, what we're expected to do as men and women, how we're expected to deal with our feelings. Notably, bipolar disorder, bipolar 1, which again is all about mania, pretty close to an equivalent gender ratio, equal numbers of men and women. And for bipolar 2, slightly more women than men, again, because bipolar 2 is more about the depression, a little bit hypomania. Bipolar 1, it's all about the mania. Which we don't have as clear gender roles about mania as we do about depression and sad feelings, right? So men aren't told not to be happy, but they are told often not to be sad or talk about being sad. So similar to the gender difference in depression, if we look at dysthymia, 3 times as common in women than men, but again, with kids, it's the same. And then with cyclothymia, it's about equivalent, so kind of like bipolar disorder. Okay, looking at comorbidity, mood disorders rarely occur alone, and for both major depressive disorder and bipolar disorders, they're most often comorbid with an anxiety disorder, and with major depressive disorder, you might also have a substance use disorder. And then, as I said before, if you have major depressive disorder and dysthymic disorder, then you would meet not a diagnosis, but the clinical term for it is double depression, which there's a clinical term for it. We talk about it because it's thought to be more resistant to treatment, harder to treat somebody that has is dysthymic and has major depressive episodes as well, because again, it's kind of this characterological built-in depression that you're trying to help them with. And another feature it's important to talk about when we're talking about mood disorders is mortality, dying. For both major depressive disorder and the bipolar disorders, somewhere between 10 to 15% of individuals will complete suicide. I don't have the numbers on attempts, but a significant number do complete suicide. And again, it's important to kind of be clear here, clinically, when you think, oh, well, if somebody commits suicide, they must have had major depression or bipolar disorder. Maybe, not necessarily. Not everybody that commits suicide has a mood disorder. Not everybody that has a mood disorder commits suicide. But having a mood disorder puts you at an increased risk for suicide. And again, the suicide attempts are more likely to happen more often associated with a depressive episode than a manic episode. Again, because why would you kill yourself when you're feeling really good? Doesn't happen very often. Might be slightly more likely if somebody has the irritability in their mania. But the taking of one's life more often associated with that low energy depression. Okay. And then mania, more so than depression, might be associated with violence, especially concerns about partner violence come into play. Because again, there's this high energy level, and if things get in the way, it can be dangerous for others. Okay, if we start talking about biological factors, looking at genetics, couple things. You know how I feel about heritability estimates, but in general I'll say that the heritability estimates are somewhat higher for bipolar disorders than for major depressive disorder. Somewhat. For whatever you think heritability estimates mean. But it's also interesting that family members of someone with a bipolar disorder are at a general increased risk for a mood disorder and not bipolar disorder per se. Right? Despite the fact that kid has or mom has bipolar disorder, now we know the kid is at risk for a mood disorder, not necessarily bipolar disorder. We know that. Statistically speaking, you're at risk for a mood disorder, but not necessarily bipolar disorder. Even though we know that when people go to diagnose mood disorders in kids, if a kid has a major depressive episode and the parent has bipolar disorder, the kid's probably going to get a bipolar disorder diagnosis even if they've never had mania, because they think, well, it's got to be genetic. If the parent has, the kid's going to have it too, which is dangerous and wrong on many levels. But that's how it works right now. But so there, like everything else, there is a strong genetic contribution to mood disorders in general. But what's most interesting are these gene-environment interactions. Right? It's where, where's this thing? I'm going to have to go back. There it is. Okay, we'll go back to it. I want to show you this graph from Caspi et al. Study. Probably one of the most important studies that's come out in the past 20 years looking at depression. And what they did is they identified people with a genetic difference. And two different types of a certain gene, two different alleles, a short allele and a long allele. And the alleles are just different expressions of a certain gene, different types of a certain gene. And this part of the genetic sequence, they figured out, seemed to play a role in serotonin transmission. Right? So if you had this type, it was associated with kind of better serotonin worked a little better. If you had this other type, serotonin didn't work all that well. And I think, okay, well, if we find people with, the long allele, the short allele, if there's a difference in rates of depression, that'll be really interesting. We'll find this kind of influence of genetics on depression. But what they found was much more interesting than that. What they found was, what you see on the picture, got people with, you have two alleles. So you either have a short and a short and a long, or a long and a long. Okay, 3 different possibilities. So what they found was, if we look at the first graph, we're looking at, on the y-axis, self-reported depressive symptoms. So if people had no stressful life events, 0 on the x-axis, we go up and look, okay, everybody's about the same. Regardless of what your genes look like related to serotonin functioning, you had about the same amount of depression. So if you looked at that, you say, okay, well, there's no difference in depression. Genes don't play a role. Right? But then keep looking at the graph, and as stressful life events increase, we start to see separation across these lines. People with 2 short alleles have more depression than the short with the long, and the long with the long alleles. So the long allele seems to be this protective factor, right? And then we see the same thing looking at it slightly other ways, with probability of major depressive episode, probability of suicidal ideation or attempt, information reports informant reports of depression. So what other people said about how depressed they were. So we're getting multiple pieces of evidence saying the same general pattern, that stress itself doesn't cause depression. the genes themselves don't cause depression, but when they interact. So and even people with two long alleles, looking at that first graph again, the more stress they had, the more depressed they got. But they're not going to get as depressed as somebody with two short alleles. But if they had no stressful life events, they look just as depressed, maybe slightly more. Okay? So there's this gene-environment interaction, which I think is just fascinating. So it's not simply genes, not simply environment. It seems to be the two working together, and that's probably the rule for most of the things that we're going to be talking about in terms of psychopathology. The other thing that genetic researchers are starting to realize is that they have a hard time documenting what they believe to be true. And largely is because they use our messy diagnostic categories as variables. And more recently, they figured out if they look at using knowledge about genetic relatedness to predict important endophenotypes, they're going to find more consistent patterns. Endophenotypes are just basic traits that are involved in disorders. Right? So instead of looking at if you have these genes or these genes and saying, okay, do the people meet criteria for depression or not, let's look at things related to that. So do you tend to experience a dysphoric mood? Do you tend to think negatively? And looking at those traits, and which these traits that we think underlie the disorder, you're going to find more consistent patterns, and it's a promising area of research, changing the focus to relation between genes and the endophenotypes, the basic traits, than looking at genes and diagnostic categories. Because again, the diagnostic categories end up introducing all those other messy variants. Okay. In terms of one thing the genes are probably influencing are neurotransmitters. And one thing we know, it's not what people once thought about, it's an imbalance or too much or too little. It doesn't seem to be that simple. In terms of the ones that are important, primarily serotonin, dopamine, and norepinephrine, although other neurotransmitters may play some role, and other neuromodulators, which are other hormones and other things in the body that affect and interact with neurotransmitters, play a role. But most research is focusing on these three things. Okay, and if we talk about serotonin, the difference seems to be serotonin receptor sensitivity. Right? People experiencing depression seem to have less sensitive receptors. So it's not that they have less serotonin. It's that the receptor is the part of the cell that when serotonin goes across the synapse and binds on, and then it will grab the thing and it will create a electrical charge by opening ion channels, generate a pulse. Right? If it's enough, the axon hillock, exponential fires, cell fires. You've got neuronal activity. The cell's working. The idea here is that the receptor isn't as sensitive, so it takes more serotonin to activate it. It's like a sticky light switch. You got to push it harder. You got to push more times to get it to go. And that seems to be what's going on with depression, is a decreased sensitivity. So you need more serotonin floating around to get the same amount of neural activity. And why is serotonergic activity important? Well, it's important for a lot of things. Including eating, sleeping, having sex, all that stuff. But one thing that it seems to influence is our ability to inhibit attention to negative stimuli. And we know that primarily from experimental studies looking at animals, but it seems to be true for humans too. But this makes sense if we think back to what I just talked about with Caspy's study and the role of negative life events on depressive symptoms. Right. So if you have poor serotonergic sensitivity, so your serotonin isn't that active, which means you're not very good at inhibiting attention to negative stimuli, which if you're not good at inhibiting attention, you're paying more attention. So when bad things happen, you pay more attention to them, right? Then, okay, well now it makes sense. So when bad things happen, people whose serotonin receptors don't work as well have a harder time not focusing on the negative stuff, and that makes them more vulnerable to experiencing a depressed mood and all the symptoms related to depression. Right? And we talk about dopamine. Serotonin also influences the transmission of dopamine because all the wires are crossed pretty much in your brain. They're not all that well insulated. And we know that too much dopaminergic activity is related to mania. We can make people look manic by giving them dopamine agonists. And then too little dopamine activity is related to depression. And this makes sense because we know that dopamine plays a big role in our reward system, right? Which is why we talk about it so much when we talk about substance abuse disorders, right? Because a lot of drugs, cocaine and whatnot, really key on some of your dopamine receptors. They make you feel really good. So a lot of dopamine feeling good, not enough dopamine feeling really bad. So dopamine's playing a role, and its role is connected to that of serotonin with depression, and also probably with mania. People that experience mania probably having high levels of dopaminergic activity. And then the third one, norepinephrine, is a little trickier. It doesn't seem to be involved so much in the origins of mood disturbance, but may play a role in their maintenance. Norepinephrine pathways often provide links between serotonin and dopamine pathways. And one thing we know is that also chronic stress, because it involves release of cortisol, negatively impacts the functioning of norepinephrine, which can then negatively impact the other things. So that's why a lot of the newer medications will target serotonin and norepinephrine. So we got to kind of get your norepinephrine stuff fixed in order for the serotonin, the things we're doing to target serotonin, to work. At least that's the theory. Again, this stuff is very theoretical because people won't let us cut their brains open while they're still alive. So picky. Okay, I already showed you that. Okay, so then the other thing to look at when we talk about biological factors is the neuroendocrine system, right? Which the neuroendocrine system is all about the interactions between the central nervous system and peripheral nervous system, and the endocrine system, which is your glandular system, all the glands that release hormones throughout your body. So chief player here seems to be the HPA axis, right? The hypothalamic pituitary adrenal axis, right? So you have projections going from the hypothalamus to the pituitary gland, which is the master gland, which then sends signals to your adrenal glands, which are on your kidneys. But it's not one way either. You also you have a feedback loop going back up into the brain as well. We know one thing that the HPA axis is involved in is the production and dissemination of cortisol, right? And cortisol is that hormone that gets you ready to respond to threats, right? And then we also know that the amygdala and hippocampus are involved in terms higher up from the HPA axis. The amygdala often sends signals to the HPA to start cranking out some cortisol, and the hippocampus often is involved in saying, okay, slow down, that's enough, threat is gone. Right, so we have all these brain areas that we seem to be playing a role, and then we think they're related to depression. And one of the biggest pieces of evidence is from Cushing's disease. Right, people with Cushing's disease have problems with their pituitary gland, which the problem with the pituitary gland until they get treatment leads to too much cortisol, and people with Cushing's disease are at an increased risk for experiencing major depressive episodes and depression in general. So I think it was like, well, too much cortisol must be associated with depression, and it does seem to be. Because chronic cortisol production is associated with decreased serotonergic activity, which might be, again, we talked about norepinephrine before, might be because the cortisol screws up the norepinephrine, which then screws up the serotonin. What do you think? Not sure, but we've got some ideas about how things might work. But the idea here is basically what you need to understand is the more stress you experience biologically, right? Because as you experience psychological stress, you experience stress biologically with cortisol being pumped out throughout your body. The less well prepared your brain is to deal with more stress. Right? Because your brain's like, oh, you're ready. But if it keeps doing that, start having parts of your brain, it causes actual brain damage. Chronic stress does, right? And then you have limited resources, biologically speaking. You can only get this stuff ready so much, and if the stress continues, now when bad things happen, we have problems dealing with emotional stimuli, possibly problems dealing with inhibiting our attention to negative stimuli, because we've been under stress so long, or for a brief period of time, at a high level. Right? So kind of a biological injury created by psychological events, because everything that's biological is psychological, everything that's psychological is biological. But another kind of piece of this is people are suggesting that early experiences are important in terms of it's possible that some early negative life experiences will have a greater effect than later ones in terms of the etiology of mood disorders, because there might be kind of these critical periods or sensitive periods in brain development where, okay, your brain's wiring itself and you're laying down the tracks, which the tracks are never fully laid down, but they're more laid down later in life than they are earlier in life. So early on, when the brain is still figuring out how it's going to work, if you have high stress, so the brain's like, okay, I better prepare for a stressful world. So I'm going to organize myself to look for danger and pay attention to danger all the time and pay attention to negative events. And if the brain does that, then you're at risk for depression. Okay, so most stuff we've talked about has been mostly about depressive episodes, which happen in major depressive disorder and in bipolar disorder. We haven't talked much about bipolar disorder specifically, which because most of the evidence is about depression, which is probably because the difference in prevalence rates. I mean, depression is way more common than bipolar disorder. That being said, everybody assumes that bipolar disorder is very much biological, but we don't know as much about how it works, biologically speaking, than we do about depressive episodes. But again, there seems to be something there about the regulation of mood. Exactly what? We're working on it. Okay. Move on to social factors. For life events are important, and for depression especially, negative life events. I should change it, not from negative life events, just to life events as the title of that bullet. But life events in general seem to be more influential on the first mood episode that you have than later ones. Again, kind of something happens in your life, and you maybe have this genetic vulnerability, biological vulnerability, and they interact together to lead to a mood episode. But once that first mood episode happens, that mood episode is associated with a lot of biological stuff going on. So after that happens, now you're more vulnerable to more mood episodes at lower levels of life stress. Right? Again, because it's almost like there's been this biological assault based on psychological experiences. But in terms of the types of life events, for depression, loss seems to be primarily the most influential thing. Bad things happen, or you may get more depressed, but if you lose somebody or something that you value, depression fairly likely. And then for mania, it's a little different. People think, oh, mania is just biological, but there do seem to be some pretty clear correlations between life events and the experience of manic episodes. And it's about schedule disruption and also goal attainment. In schedule disruption, about if things always happen a certain way and then your schedule changes. And usually more of the research is about really kind of significant changes where you fly to Hong Kong and now you're going to bed, waking up at different times. So these kind of shifts in what your circadian rhythms need to do might trigger manic episodes. But other schedule disruptions have been associated too. People going from night shift to day shift, that kind of thing. And then the other thing, which is interesting, goal attainment. So somebody gets a promotion and they have a manic episode. So again, it's kind of like I feel a little good, and that momentum of feeling good carries me into feeling really good, and now I'm into this manic episode where I'm going to Vegas, maxing up my credit cards and getting in trouble. Importantly though, life events, whether or not they're profound losses or huge goal attainments, the impact they have seems to differ across individuals. Not everybody who loses somebody will have experience depression. And part of the explanation, part of it always is obviously some sort of genetic, biological vulnerability, but another part of it is this cognitive aspect where the meaning somebody ascribes to an event influences the loss. So again, you lose your goldfish, you may experience depression. Now, your childhood dog, who you've known for 15 years, they die. That's probably more likely to trigger a depressive episode than losing your fish. Unless you really like fish. But for me, anyway, the dog would be. I would attribute more meaning to it, so it would have more power. So it's not just life events, it's how you think about them and if they're personally significant to you. You know, if you lose a job, what does that mean to you? Is that having a job and being that person, is that central to your identity, or is it just the job and it sucks, but I find another one? Right? So there may be some differences there. Another interesting phenomenon is this idea of a stress generation effect. And this is the idea that some of the negative life events in the people with mood disorders experience may be because of things they do to themselves. possibly as a result of the first mood episode. So they're depressed, and then they start making poor choices, having difficulty concentrating, calling in sick to work, and then that causes more stress, which then exacerbates the depression. Or maybe other kind of personality variables that were correlated with depression are also correlated to the stress generation. So having poor interpersonal skills, or poor choices in romantic partners. Those things can lead to negative life events, which then make your mood worse. Another important social factor is social support. Obviously, people that have less social support are at greater risk for mood episodes. And then related to that, there's this idea that low rates of positive reinforcement play a role, especially in depression. This is Lewinson's theory, right? Which is that when people do things that typically result in positive reinforcement, and they're happy if that happens, right? So hit the button, the Coke comes out, everything's good. Now, if you do something that typically does result in positive reinforcement, but it doesn't, so you work really hard and you don't get that raise, so you have this, you don't get contingent reinforcement. It leads to dysphoria, just kind of bad mood. And that happens, you mope around, and the social environment reinforces your moping because they feel sorry for you, but then your moping will be reinforced, so you keep doing it. But then eventually your moping will contribute to ongoing low levels of response contingent reinforcement. So you won't get a raise anymore. Related to that is the idea of social rejection, which Coyne focused on the impact of these behaviors on interpersonal interactions, stressing that the moping is done in order to connect with others, which works at first, but eventually people get tired of it, and it leads to rejection if we don't respond to their attention and caring by being happier. Hey, thank you. If we don't brighten up pretty quickly, then they reject us. Right? Other theorists agree that social rejection is important in ideology, but then they postulate, they hypothesize that this rejection comes not from you moping because you're depressed in the first place, but some deficit in interpersonal functioning. People that just aren't good at seeking out positively reinforcing experiences from others are more likely to experience rejection, and then that rejection will lead to depression, not the depression leading to the rejection. So might be one or the other, might be both, might be different for different people, right, most likely. Last for etiology, looking at the cognitive factors. Beck's cognitive theory of depression, one of the most influential theories in our field, looked at a lot of things. One, talked about self-schema, right? We all have certain beliefs about ourselves and tendencies to interpret information about ourselves in a particular way. Right? And these beliefs and processing proclivities make up our self-schema. Right? We know this schema is very powerful. Right? Like you've heard about the cocktail party effect. You're at a party, you're talking to friends, and across the room, amid the stereo and everybody talking, you hear your name. You pick that name out from all the chatter because we're hypersensitive to things about ourselves. We spend a lot of time thinking about ourselves. We pay attention to things about ourselves. We have well-developed self-schema for the most part. Now, Beck, didn't come up with the idea of self-schema per se, but he said people with depression have depressed self-schema, right? And that the experience of depression, which is emotional, physical, cognitive phenomenon, is brought about by this depressive self-schema, where people develop negatively themed beliefs about themselves and a tendency for negative appraisals, especially related to failure to attain goals, right? In that we develop these self-schema, these depressive self-schema, due to interactions that occur during development. Right? So, in addition to kind of biological stuff, things that happen to you in your life will make you think negatively about several things. And those things we can sum up in the cognitive triad. So negatively about yourself, about the world, and about the future. Right? So that the depressive schema influences your perspective in these three areas. So I'm kind of bad, I'm not very good. The world is a mean, cruel, dangerous place. I can't expect much from anybody else. And then the future doesn't look good. Things won't get better. Nobody ever changes. Right? So those kind of three pieces of the schema seem to play a prominent role in depression. And people experiencing depression do report negative thoughts in all three of those areas. So those are kind of the beliefs in the schema. And then the cognitive distortions, these are about the faulty cognitive processing tendencies associated with the schema. So cognitive distortions are tendencies to distort information, usually incoming information about the self, and you distort them to be consistent with your negative views. Examples might include catastrophizing, where you get a bad grade on a paper and you go, oh, some people go, oh, I got a bad grade, that sucks. Man, I might fail this class, that would suck. And maybe they'll stop there. Somebody else who catastrophizes will go, bad grade on this test, that sucks. I'm going to fail this class. Oh my God, I'm going to fail out of school. Oh, if I fail out of school, I'll never get a good job. Oh, I'm getting up homeless on the street and nobody will ever love me and I'll be all alone. It's a quiz grade. Right? So going from one negative event and then taking it to something much, much worse is catastrophizing, which is more common during a depressive episode. Selective abstraction is another one. And this is when you focus on only the negative details of some event and then generalize that to everything. Kind of the one bad apple does spoil the bunch. Somebody gives you a TV. Well, that's awfully nice. Thank you for the TV. But the remote doesn't work. The remote doesn't work. Oh, this TV is crap. I always get bad presents. Everybody hates me. You got a friggin' free TV. You can go buy a universal remote, but they don't focus on the big picture. They focus on the one little negative thing and focus on everything is bad. Related to Beck's theory, we have some attribution-based models, which focus on one aspect of cognition, the explanations people make for successes and failures, and it largely based on the early work on learned helplessness by Seligman. Right, he had the dogs where it's fairly cruel work. Dogs would be in these little cages, and they would shock them. But then the dog would learn if you move from here to here, or push this lever, you could do something. Usually moving, you could move, and you could avoid the shock. And the dogs that avoided the shock were happy. Life is good. That shock kind of sucked, but they were fine. They're still happy, tail wagging dogs. So you do that for a while, and then you make it so they can't avoid the shock. So they move just like before, but now it doesn't work. The shock's still there. It doesn't turn off. And what he showed was those dogs looked depressed. And then he hypothesized, because they looked depressed, that they looked depressed because of they developed a sense of learned helplessness. That they developed a sense no matter what they did, bad things would happen. And when you have that attribution, that explanation for bad things, that I can't control them, that's what depression is about. Very influential theory, and then it's been elaborated on by multiple others. And now we'll look at a little more detail in terms of attributional style related to negative or positive events, and looking at when something happens, you look at the locus of the attribution. Is something, it happened because of me, something internal, or external, because that's something out in the world. Is it something that's stable or dynamic? So it's always going to be this way, or it could change any minute. And then specificity. Is it just this one thing that was good or bad, or is it everything? And what they found is that people with depression tend to, for negative events, to make internal, stable, global attributions. So if something bad happens, you fail a test. I'm stupid. Not that the teacher's a jerk or the test was unfair, or I was unlucky. Right? It's me. It's stable. I'll always be stupid. It's not just I could study harder next time and do better. No, can't do anything about it. And then it's global. It's not just that I suck at calculus. I suck at everything. Right? So internal, stable, global attributions for negative events, and then external, unstable, specific attributions for positive events. So not only bad stuff happens, you make these attributions that make you feel worse about yourself, but something good happens, and you think, oh well, life sorts itself out, the good with the bad. But now when the good happens, you go, oh yeah, but that wasn't me. It was an easy test. Everybody probably did well. Unstable. I probably won't do good on the next one. And specific. And it's just this one test. Not like my other classes. Probably even other tests in this class, I'll probably still fail. Right? So there's this these differences in explaining positive negative events that are related to the experience of depression, possibly in a causal way, definitely in a kind of correlational way. Okay, but in terms of etiology of depression, as you've probably hopefully gathered from all this, it's a lot of stuff, and it's probably an integration of this stuff. So there's biological vulnerability. Right? Part of that's genetic, and part of it is life experiences that have influenced your biology, because your biological functioning, the way your brain is right now, is the result of your genes, your experiences, all the foods you ate, all the drinks you ate, how much pot you smoked, how much TV you watched. All these experiences up to now shaped your brain. All the stuff you continue to do will continue to shape your brain. Right? So there's that. Then there's your thinking style and how you think about yourself, which is probably related to experiences you've had and what people have told you. And then also your social environment, which your social environment, you pick it to some degree, right? You surround yourself with certain people based on your personality and whatnot. But then other things, you're stuck in a certain place. You're born here in the States and not in Afghanistan. Right? You didn't have any control over that. And there's some social factors beyond your control that will also contribute to your experience of mood episodes. And it's all these things working in concert in a probably very complicated way. Okay, looking ahead to proposed changes in the DSM, talking about adding disruptive mood dysregulation disorder, which is characterized by angry outbursts in response to common stressors. It's going to be present before age 10, but can't be diagnosed until after age 6. And this is being talked about being put in there because in the past couple of years, one of the popular things to diagnose kids and teenagers with is bipolar disorder, if they get really pissed off and yell at their parents or get in fights or burn things down. Instead of just conduct disorder, saying, oh, it's mood disorder. And the reason for that is we have medications for mood disorders and not as clear what to do for in conduct disorders. You have to do behavioral interventions and treat them differently. So easier to say, oh, it's probably bipolar. Let's try some heavy sedatives. So anyway, a lot of kids have been diagnosed with bipolar disorder. So instead of they're looking, well, maybe we'll just call it a different thing and call it disruptive mood dysregulation disorder. And they're saying that probably because a lot of these kids don't seem to really have bipolar disorder. They don't, even as they get older, they don't grow into, as you would expect them to, the pattern that people with bipolar disorder show. So we'll see what happens with that. Another one which has been discussed for a long time, premenstrual dysphoric disorder. People that have pronounced symptoms, mood symptoms that cause impairment and occur during the final week before the onset of menses. And this one, kind of a politically charged diagnostic category in terms of, in one camp, people saying you're pathologizing, over-pathologizing women, that they have may have some mood symptoms related to their menses, but it shouldn't be diagnosed. In the other camp, you have people saying, no, some women do have symptoms that cause impairment, and they can't get help unless you diagnose them. I don't know if that's a valid argument or not. But arguments ongoing about that one. Possibly also the introduction of a mixed anxiety depression disorder, where a person has 3 or 4 symptoms of major depression, and then also anxious distress, which is 2 or more symptoms of anxiety, irrational worry, preoccupation with unpleasant worries. It's kind of like generalized anxiety sort of type of stuff. But you don't have enough criteria to meet diagnosis of major depressive disorder or another anxiety disorder. Interesting idea. And then chronic depressive disorder, renaming dysthymic disorder to that, with some other slight changes in the wording. Okay. So a lot of potentially new disorders coming up. We'll see. Okay. Summing up. So the major mood disorders to know about: major depressive disorder, bipolar 1 and 2, dysthymic and cyclothymic. Major depressive disorder, only major depressive episodes. Right? Bipolar 1, a manic episode or mixed, and then it could be any other episode. Can have depression, can have hypomania, whatever. As long as you have a manic or a mixed, good to go for bipolar 1. Bipolar 2, got to have a major depressive episode and a hypomanic episode. If you ever have a fully manic or mixed episode, boom, you're kicked out of bipolar 2, back into bipolar 1. Dysthymic disorder is your chronic depression. Cyclothymic is kind of like chronic bipolar, so some hypomania and then some depression, back and forth, but never to the point, at least for a long period of time, where you meet criteria for a manic, mixed, or depressive episode. So figuring out which disorder somebody has largely involves figuring out what their current mood episode, if they are experiencing a mood episode, what it is, and then what are the mood episodes they've met criteria for in the past. Okay. Other stuff you need to know is if they have psychotic symptoms now or in the past, did they occur only during a mood episode or not? If they had them outside of a mood episode, then we're looking at either a psychotic disorder or schizoaffective disorder. If it only happens in the course of a mood episode, then it's probably one of these mood disorders with psychotic features. Okay, that's all for now. Take care.